incredible doctor. Every day we work together, and every day I learn something new from him. Over to you, sir. Shrikant sir, Pawan sir, if at all you can unmute and would like to conclude or to add something, sir.
Sir. Sir, am I audible, sir?
Yeah, sir, you're audible, although it's very less, but it's audible, sir.
Sir, now,
Yeah, sir, better than before.
yeah. Thank you, sir. Uh,
Yeah,
it has been a
yeah,
great series of. Uh, okay, sir. Pawan,
sir,
sir, please
very.
carry on.
Sir. Sorry, sir. It's my customary on behalf of Indian Academy of Pediatrics, Twin Cities branch and Indian Academy of Pediatrics national branch. So this series is a very favorite of everybody. I think Shrikant also joined. Dr. G.V. Lanchari sir has joined Shrikant. And what about Dr. Suchitra is also joined?
No, sir. No, she has not
Okay,
joined.
no issue, no issue. So this is a prestigious series which was started last year. Now it has come to conclusion. I'm very happy that it is going to end with a blockbuster session by Dr. Yoga Nagendhar sir, who is as rightly said by Dr. Nitin. He is a man, a pediatric surgeon with a lot of compassion. I have seen how he has won many awards, how relentlessly he worked across the state. I think seeing him always inspires me at the personal front. So now I think I request Dr. Shrikant, who is the secretary, treasurer of IAP Twin Cities branch, to give his opening remarks before. And gratitude to you, Dr. Yoga Nagendhar sir, and also Nitin sir for conceptualizing this. I really remember how we both together has created a name Pac-Man and how it has become a blockbuster hit. And we have 3 WhatsApp groups with almost all houseful groups there. So with your dedication and passion, we made it possible. So now it's going to come to an end with a blockbuster session by Dr. Yoga Nagendhar sir. Over to Dr. Shrikant for the remarks and then speaker.
Sir. Thank you, Nitin Chawla, sir, and Pawan Kumar, sir. On behalf of IAP TCB, greetings from our IAP TCB, sir. It has been, as rightly said, I have been following some of the sessions of Pac-Man series, which has been brought by Nitin Chawla, sir, with Pawan Kumar, sir, has been a great one. And in pediatric acute abdominal pain or distension, which needs very careful attention. So over to you, Dr. Nitin Chawla, sir. Thank you, sir. Thank you. Thank you for this good series. And I think it is the last session, sir. Nitin
Yes,
Chawla, sir.
yes, sir. Yes, sir. It's the last session, and I think the master stroke should be played with master in the batting field, and Yoga Nagendra sir will do justice. Thank you, Srikant sir. Thank you, Pawan sir, for incredible support. Dr. Sri Krishna sir is not available, but he was one of the main pillar to make it happen. And with all the blessing of seniors, today we are on the last stage. Thank you, sir. Thank you, Yoga Nagendra sir. You can start your presentation, sir.
Thank you, Nitin, for your kind words. And Pawan, actually, thanks for your excellent words. And thank you, Shrikant, for giving me the opportunity. And hope I'm audible. I'll go to the next slide.
Yes, sir.
So, with this slide, actually, I thought actually all of us, whenever we see any abdomen which the baby is crying with abdominal pain or a distension, all of us will be worried: is it a surgical abdomen or is it a medically manageable abdomen? So this question persists and it will persist for a long time, even after evaluation also. Many times we'll be scratching our head whether it is the correct diagnosis or not. And should we be really worried about or not? There is a big question. And this decision making still is an enigma, even for pediatric surgeons, pediatricians, all of us around, yeah, however senior he might be. So there are instances when actually we might be thinking it is not surgical and suddenly it turn out to be a surgical abdomen. So So I'm Yoganagin, the pediatric surgeon. Actually, thanks a lot for your kind words. And most important is actually whenever you see an abdomen, actually which is suspicious, when you should be calling a pediatric surgeon is the most important doubt that you might be having. So with all correlating history and past and present, so history is very important. Even though we are running in the era of CT scans and whatnot, all investigations. Even then, history is very important, and past and present, both histories are equally important. And after the initial examination, actually, any doctor who's seeing a child, he should be having one mental makeup. Actually, what is the possible diagnosis? So, what is the differential diagnosis I'm coming up with? That is very important, and he should be having his own plan. And then all the relevant reports which are important. And with all these things, actually, they should be consulting a pediatric surgeon, so that whenever actually someone asks a question, we should be ready to give an answer immediately. That is what is expected from any postgraduate. And truly speaking, actually, post-graduation is continues into our future life. Throughout our life, actually, we'll be students, and we are answerable to many people, not only the examiner, but the most important examiner, as we all of us know, is a parent. So as usual, actually, all of us know that abdomen is a Pandora box. So, so whenever any you see an abdomen, actually, you really don't know whether it is going to fit into exactly this diagnosis. Even appendicitis also clinically, actually, differentiating is not that easy. So, if at all, whether the patient abdomen is having guarding, rebound tenderness, and rigidity is there, this clinical assessment we should be doing. And ideally, this should be because the child is crying, you can't clearly assess whether it is really rigidity, really rebound tenderness or not. So sometimes you may have to do what is something called a real-time examination, what we examine now, and we'll be examining when the child is really comfortable. So as pediatric surgeons, we go and knock the door. We'll tell the parents not to wake up the child. We'll go to the child, examine the patient, and then we'll start taking the history. This is a different type, but in exam, we cannot tell. But truly, in real life, this is what happens. First, we'll try to examine the baby first, and then we'll start taking the history. This is maybe I should not be telling in an open forum where some students might be there, but this is the reality. And umbilicus is one thing which will give a lot of information. So the redness around the umbilicus says something is problem with the intestines. Sometimes if the child has got intestinal gangrene or necrosis, there will be periumbilical redness. This is very important. And is the umbilicus stretched or not? And is the umbilicus having an associated umbilical hernia? Is the umbilical hernia covered with actually redness or not? All these things are very important. So I always tell you should be like a Sherlock Holmes. So my teacher used to tell Sherlock Holmes should be a textbook for all the physicians, all the clinicians, all the doctors. So and gait of the posture of the patient in the bed. So is he wincing with pain and is he completely folded? That means he's in severe pain. Usually it is seen in the pancreatic pain. And depending on that, and if at all, if it is rigidity, he won't be moving or tossing anything. He won't move at all. So that means it is a case of peritonitis. So what is the position of the baby? That also tells about the diagnosis. So that observation is very, very important. So most important doubt actually all of us will be having is whether to open or not, whether to call the surgeon or not. After the surgeon is called, where the surgeon's doubt is whether I should open or not. So if at all, if I'm opening, should I be doing a laparotomy? Should I be doing a laparoscopy? So all these things are very important. And sometimes actually you won't believe actually masterly inactivity is the answer for most of the pain abdomens. So this actually in coming slides I will be talking actually enema is a short gap where actually we'll be able to reassess and re-examine the patient, and then we'll be deciding whether really if constipation might be the reason for the pain abdomen. So we'll talk about in the coming slides. And if at all, if we want to see abdomen, actually you can divide it into quadrants or 9 regions or 10 regions. So quadrants, if you see, actually right upper quadrant, left upper quadrant, right lower, left lower. So these things actually will be differentiating, and accordingly, the anatomy and the organs situated in that region, actually all those things will be decided, and accordingly we'll be having our own differential diagnosis. And same thing can happen with the regions also. Epigastric region usually tells something which is to do with foregut, and periumbilical is usually something to do with the midgut problems. And pelvic regions, hindgut problems, and also pelvic organs also will be having a similar problems. So here I was talking about actually quadrants. What all are the things which you are going to see in the right upper quadrant? In right upper quadrant, actually, all of us know actually liver. Acute stretch of any organ can lead to pain. So a solid organ suddenly it increased in size. Liver can be a cause for the pain. And something under the subphrenic area, actually, that also can lead to pain. And gallbladder is another condition actually which we'll be seeing. Actually, in the coming slides, we'll discuss in detail. And the bile duct, if at all, there can be perforation, there can be distension, there can be full ducal cyst, and all these things we'll discuss in the coming slides. And coming to the left upper quadrant, and all of us know stomach, acute distension of the stomach itself can lead to pain. So even by simple belching, actually, you'll be having actually pain relief. Even so, that's why burping actually gives significant relief in most of the kids. And spleen, as we discussed, acute stretch in any solid organ can lead to pain. And duodenal pain, pancreatic pain, actually, all these things will be there in the mid abdomen as well. So right iliac fossa, as we are more fancily worried about, is about the appendix. It is not only about the appendix, it is something to do with the mesenteric nodes or mesenteric adenitis, and even the typhlitis, actually, which we commonly ignore. So the history of a previous day or 2 days before, whatever he ate, and did he pass motions, all these things are going to add to the pain abdomen. And left colon, left lower quadrant is significantly classical of actually typical gastroenteritis infections, or it might be simply because of the loaded colon which is stretching the intestine. Stretch of the intestine can lead to the pain. So most important, actually, I tell about this slide, actually, that is the 10th compartment. If at all, if 10th compartment is ignored, so 100% a young child, he won't be interested in telling, actually, I have problem in my scrotum or testis. So it is very important that we should be examining our 10th compartment of a child. So it can be a simple epidermolysis, it can be a torsion of the testis, or it can be the varicocele. Actually, it will lead to continuous nagging pain. So accordingly, actually, we have to treat the child. And so most important is the 10th compartment. If you miss it, you will be missing a significant part of your examination. So emergency scrotal scan is required irrespective of the timing of the day. So often they'll be coming, actually they'll be presenting very late night. So I often get called only at 9 o'clock. Unfortunately, 9 o'clock, most of the radiologists are not available. Even then, I tell them clearly, some of these parents will tell, can I get the ultrasound done tomorrow? So we have to tell, no, no, get the ultrasound done today itself. And the most important part is documentation on the paper, that you documented that you ask for the ultrasound the day, night, same hour. Because after 6 hours, after doing a detorsion or whatever procedures, there might not be much of result. So that's why torsion testis, it needs to be treated as early as possible. So from that time itself, you should tell the child, likely try to keep the child NBM, so that we'll be ready to prepare the patient for if any emergency exploration is required. And nowadays, actually, the treatment for torsion of the testis is not orchidectomy. Nowadays, most of the time, actually, what we are planning to do is that what is we call as salvation. So we'll try to do a fasciotomy. We'll just put one small nick over the testis. Here also, we can call it as a compartment syndrome. So we are releasing the pressure from the compartment. We'll see if the bleeding is there or not, and according if the bleeding is there, and then we'll be putting one what we call it as a tunica vaginalis flap. And over this fasciotomy, we'll be putting a tunica vaginalis flap, which will be vascularizing the thing, and then we are leaving it like that. So most important part here, where all of us should understand is, what about the other testis? Tomorrow, that testis also can go into torsion. If at all, if that testis also can go into torsion, then we tend to do what is called as a orchidopexy prophylactic on the contralateral side. So we are protecting the kidney. I always compare it with a revolving chair. So revolving chair, if you fix it to one side, actually there is no possibility of it going into torsion. So this is very important, and this always should be considered. And if at all, if by mistake, if it is not done, if it is done by someone else in some remote area, we have to tell the parents, yes, this needs to be done. So the patient may be recalled to go for it, or contralateral orchidopexy on the other side. And varicocele, various reasons might be there. Sometimes actually there can be pressure, actually renal tumor or something might be pressuring, putting a pressure on the veins, and which can lead to varicocele. Initially, low grades, yes, scrotal support is enough, but often actually in a child, usually he'll be running around, moving around. There'll be a grade 3 or grade 4 actually type of varicocele that may require a varicocelectomy, even if it is a child. So usually it will be seen in tall, long adolescent boys. So we do actually surgery for them. So subacute intestinal obstruction is another interesting word and a topic, and uh, we let us go into the etiology and the management. And what all can lead to a subacute intestinal obstruction is something like a neglected appendix perforated, and it is not managed, or the appendix has gone to some local addition in the right iliac fossa, and the child is vomiting and he's getting recurrent abdominal pain. So if all these things combination is there, so then also actually we'll be getting a neglect subacute intestinal obstruction. Suppose even a tuberculous abdomen, actually, a doughy feeling of the tuberculous abdomen is very interesting finding, but actually, often, actually, it is a clinical diagnosis and detailed history is what is going to clinch to our diagnosis if it is a subacute intestinal obstruction. And previous history of operation. So I told actually previous history is very important. If at all, if one operation, actually, even a CHPS, even an appendix, even a interruption, reduction, or something, all these things can lead to adhesive obstructions. So unfortunately, I often tell actually adhesive obstructions are a curse to a surgeon because for no mistake of his, actually he will be cursed because actually because of his operation, the child went into adhesive intestinal obstruction today. So so if at all if it is there, so all these things conditions actually will lead to one common complaint: acute abdominal distension and bilious vomitings and vague abdominal pain, which is not relieved by any medicines. So sometimes actually simple chronic constipation can lead to subacute intestinal obstruction if the constipation is prolonged and long-standing, and so many fibromas are there. And sometimes actually NEC strictures are less recognized, but often NEC strictures are one of the common causes for subacute intestinal obstruction. And for this, a lot of suspicion should be there. He was there in NICU for a long time, and he took antibiotics for a long time, and all these things should be there. And later we'll be evaluating by doing actually some contrast studies, and then we'll be diagnosing if the child is having stricture, and proximal dilatation will be there, and distal narrowing will be there. If this is classical of a stricture which will be seen. And sometimes even tumors and polyps can be reason for actually subacute intestinal obstruction, though rare, but they can still be a cause. So they often present with recurrent abdominal pain. And initially, surgery is not the option. Initially, observation is the option. So what we do is actually as a routine for every patient, we put the rice tube and we'll be aspirating, and we'll see if the green aspirates are turning into white aspirates. That means actually intestine motility has started. If at all, if it is starting, and then we don't touch a subacute intestinal obstruction. Only if it is not working out, then we'll think about doing a laparotomy. And laparoscopy, usually we'll try to keep it at a bay because laparoscopy sometimes actually the gaseous distension that we cannot get, and additions sometimes actually it is not comfortable for a surgeon to go in between the intestinal loops and do a complete job. So that's why laparoscopy is not that popular in subacute intestinal obstructions or any intestinal obstructions for that matter. Today, I thought actually I made this slide specially because there are some rare conditions actually which all of us tend to ignore, and there is one standard saying that actually if at all if there is a fever and no finding anywhere, and if it is associated with pain, that can be subphrenic abscess. So a pain and a fever unexplained, and none of the tests are giving any clues, then it is a possibility that it can be a subphrenic abscess. So in our MBBS days, actually all of us are interested in reading the Bailey and Love Dietl's crisis. But it is less often talked about after the textbook days. But in pediatric surgery, in fact, actually we see significant number of Dietl's crisis. So that is because there will be a crossing renal vessel, and it will be crossing the renal vessel, and it will be crossing across the PUJ. It is not a true obstruction, but it obstructs. Whenever the pelvis is grossly distended, it will obstruct. But because of the weight, actually, it will slowly start draining out. Then the pain comes down. This is what we call it as a Dietl crisis. And simple ultrasound can diagnose, but actually, renal angiography is one thing which will clinch to a diagnosis. It that it is a Dietl crisis because of the PUJ obstruct narrowing because of the accessory renal artery. And ureteric colic is something which all of us should keep in mind because, and if it is associated with actually hematuria, yes, ureteric colic is a reason. And in history of, again, coming back to the history, there will be history of urinary tract infections and there will be history of hematuria and scalding pain. If all these things are there, actually ureteric colic might be a possible diagnosis in the differential diagnosis. And we'll be going for ultrasound. Ultrasound usually tells diagnosis, and then we'll do a CT urography just to check if there are any associated anomalies or can be associated. Actually, there can be associated stones also. So not only the ureteric stone. So the answer is get rid of the ureteric stone, and that will settle the problem. And uh, I said actually the clinician should have that mind bend that to think about actually various causes. If at all, if any history of sepsis or infection is there, and vague abdominal pain is there, and vague abdominal distension. So mesenteric thrombosis is another condition which need to be kept in the mind. So if mesenteric thrombosis is there, if you don't intervene and diagnose properly, invariably it will lead to mesenteric venous thrombosis. And the solution for that is actually we have to remove the whole of the midgut, and which can lead to actually a massive gangrene. And the only answer for that will be after the operation. Small bowel transplantation is the only answer. Till that is done, actually patient can go into so much of morbidity, and finally he may succumb to death as well. And in females, especially, actually, what we see a condition called primary peritonitis, where uh, because of actually frequent urinary tract infections or vulvovaginitis, there can the organisms can migrate into the peritoneum, and then it can lead to actually what is called as a primary peritonitis. Diagnosing a primary peritonitis is very difficult, and it is more of a clinical diagnosis. And there are many conditions where actually surgeons must have done a negative laparotomy and they found out that there is no reason and only some little bit of mild ascites will be there, mild infection can be there. It usually follows a pelvic inflammatory disease, especially it is showing more commonly in the female children, girls. And fatty hernia of linea alba is another condition which mimics a gastritis. Usually above the umbilicus, actually we will be having a fatty hernia, a small fatty hernia. It will be of the size of a peanut and it will be having that pain. So none of the ultrasounds also actually can diagnose. So that high index of suspicion should be there in the mind. So fatty hernia of linea alba is some other condition where if all of us should suspect whenever there is a chronic pain in especially in the midline, especially he'll pinpoint to one place also. That is when actually we should be thinking it might be a fatty hernia of the ligament alpha. So the answer is simple. Remove that fatty hernia. It is a lifetime solution. So and all of us know actually testis can be undistended. So if this undistended testis is still in the intra-abdominal area, they can lead to orchitis in the testis and also most importantly, a torsion of the testis can be there. High index of suspicion. Undistended testis, severe pain abdomen. So maybe we should be thinking about actually torsion testis because again, timely intervention, if we don't do it, actually it will go into gangrene. And the most important, though I kept it in the rare conditions, it is not rare. It is a common condition. That is actually a constipation. So I'll come in detail about the constipation in the coming slides. So mesenteric thrombosis, actually we were discussing, actually this is an important thing, actually where a high degree of suspicion should be there. And usually there can be history of trauma or actually some sepsis. And arterial thrombosis are very rare compared relatively. Venous thrombosis are more common. And unexplained pain, at least I have a suspicion and get a CECT abdomen, actually that clinches to the diagnosis. And when actually we can call the interventional radiologist, he'll be doing some endovascular procedure as a remedy. And if at all, if it is diagnosed as early as possible, then we are going to give the child a life. or else actually we are going to give a child a miserable morbidity and a mortality. And because of the bowel resection that we have to do. And if not timely detected, it can lead to what we call as abdominal compartment syndrome as well. So shifting radiating pain actually we see often actually, but we underdiagnose this shifting radiating pain. It is because of the mesenteric adenitis, and it is a purely a radiological diagnosis. Radiologist will tell actually yes, this is there, and often we'll be thinking that it is a clinically it is more or less like appendicitis, but uh, strong suspicion actually shifting. If the patient is shifted to one position, lateral position, and supine, then if it is shifting, then we should suspect that is it a mesenteric adenitis, and usually the answer is actually with the medicines and no need for surgery, and within a month actually all the problems will be settled. And correct diagnosis in these patients is vital, and it definitely avoids an unnecessary surgery. Constipation is the most ignored common cause for recurrent abdominal pain. Most of the parents actually, when they come to us, definitely a parent will definitely deny, telling that my child doesn't have any abdominal any constipation. So even then, actually, even though the parent child is ready to tell, parents sometimes they won't. They're reluctant. They tell they don't. A child has got no constipation. So my boss used to tell, if you miss noticing the bottom, you're going to miss a lot. So my teacher used to tell, actually do a PR for all the patients, unless if only in an imperfect anus case you should not do. So, but in a case of fissure also, post constipation, ideally we are not supposed to do a PR. So in during my post graduation, I just wanted to add this story. During my post graduation, in the OPD, actually, my boss used to see a patient of a pain abdomen. He used to send the patient to the ward, and he used to tell, get a enema in the ward, and then Dr. Yogananda will come and examine the patient. So I used to think, actually, this doctor is torturing me. This teacher is trying to torture me. Later, I understood in my clinical practice, around 30% of the pain abdomens, the answer is enema. So in some hospitals, they used to call me Dr. Enema, because I used to tell, first give proctoclasis enema, then we'll see again. So this is what actually my teacher has taught me. I'm practicing and I'm successful in most of the cases. So whenever pain abdomen is there, first thing actually, some parents deny. You just believe me, in your clinical practice, you will understand this point. Parents just deny that my child has got constipation. So we have to give enema after evacuation. After some time, the spasms in the intestines or the distension of the intestines will start reducing, and then we have to go and re-examine, not immediately after. So uh, this, uh, so then actually you'll understand that there is no pain abdomen, or it has significantly reduced. That itself clinches to the diagnosis that constipation is the cause. So some interesting conditions also we'll try to go through. Actually, umbilicus, as we discussed, it's a very important structure, and in this umbilicus, actually many things are hidden in that. So it can be starting with the vitreointestinal duct, or it can be because of the patent urachus. So both of these things actually, if they get infected, if the tract gets infected, if the cystic connections which are having in the tract, if they get infected, it can lead to severe abdominal pain, which we cannot detect actually clinically by any of the investigation most of the time. So it is a clinical judgment which is more important. So Meckel's diverticulum actually, or the patent urachus or vitreointestinal duct communications, all these things are important structures which need to be discussed. And so they present in one way, actually, either it can be abdominal umbilical discharge, or it can be the omphalitis, actually, and with severe pain, and there can be swelling. So vitreointestinal anomalies are common, and it can be a cystic lesion. Often we see in the newborn period or post-newborn period, just below the umbilicus, actually one cystic lesion might be there, which can be detected by ultrasound. But parents tend to ignore, and they'll come up to us with an infection in this vitreointestinal remnant, and then it will lead to actually a omphalitis or a periumbilical swelling or a umbilical discharge or pus. So often we'll be called for this, and then actually what we tend to do is actually you can do two things actually. Why directly go for surgery? The other way of doing it is let out the pus, let the pus come out, let it become a non-acute condition, and then do the operation. This is the best way of doing it. So we should not, as a surgeon, we should understand when to hurry, when not to hurry. So sometimes if you try to hurry up, actually you'll be doing a major, massive surgery because it is so closely adherent to the urinary bladder. So there is a possibility that actually uh, it can lead to uh, bladder injuries as well. So patent urachus is one condition actually where actually you have to see if urachal cyst is infected or not, and if at all if infected, actually that's what I'm trying to tell. First drain it, then electively do excision later phase of time. So or else it will become a major operation, or else the bladder injuries can be a possibility. So again, actually coming back to the vitelline intestinal duct abnormalities, it can be a simple Meckel's diverticulum, or it can be a band which is connecting Meckel's diverticulum to the umbilicus. It can lead to subacute intestinal obstructions or intestinal gangrenes, or it can be a simple cord without Meckel's diverticulum also, and it can be a simple cyst actually which can get infected and present later. So all of us know actually Meckel's diverticulum actually can present as Meckel's diverticulitis, or it can be because of the perforation of the Meckel's diverticulitis, or because of the band, it can lead to band obstruction, or if it is because of the bleeding, actually it can lead to a massive bleeding. Sometimes actually the hemoglobins will be falling to a significant low levels as well. So all of us know the standard rules of Meckel's diverticulum. It can be seen in 2% of the population, and it can be seen 2 feet away from proximal to the ileocecal junction. And in only 2% actually of the patients actually it can be symptomatic, and in less than 2 years actually the symptomatic problems are more often, and 2% of the Meckel's diverticulum can have what we call it as ectopic tissue, which can be presenting. It can be gastric or pancreatic. That is when actually it can lead to a massive bleeding. So usually these two actually some gastric gastritis or pancreatic tissue are the one of the lead points for causing the uh, acute bleeding. And sometimes simple metal diverticulum can lead to acute intussusceptions as well. So then what we'll do actually, if at all bleeding is there, how will we diagnose? Yes, if at all if bleeding is not there and suspicion is strong, you can go for radionuclide study, which is metal scan. And if at all if the bleeding is there, what we tend to go is called as a bleeding scan. So both are totally different, and both need to be done on 2 separate days. We can't mix and match. So clinical judgment is important, and we should be ordering the investigation according to our clinical acumen rather than actually just randomly writing all the investigations. So incidental Meckel's actually we'll be seeing in some simple operations actually many times. So, but if at all if the mouth of the Meckel's diverticulum Meckel's is actually wide, so if the mouth of this Meckel's is wide, so then we'll tend to ignore and we'll just leave it like that. And so not operating, and if at all if I'm not able to feel anything like a gastric tissue or a pancreatic tissue, I'll just leave it like that. So that is acceptable. So if at all if any of the or if the neck is narrow, or if anything is felt in the submucosal area, then it is always advisable to remove it. So the answer for this is Meckel's diverticulectomy if nothing is felt. If something is felt actually in the submucosal area, then we'll try to go a little bit wide so that it will be preventing any future further gastric or pancreatic remnants. So there are various ways of operating these umbilical issues. Actually, one is actually open operation. The other one is actually laparoscopic operation. So it is actually individual decision. Subumbilical incision we can give, and then a simple operation. It's a daycare operation also if it is because of the patent urachus. But if it is because of the intestinal duct and we have to resect the intestine or the Meckel's diverticulum and we have to join it again, maybe the patient may have to stay for 5 days. So till we go in as a surgeon, we don't know whether we are going to keep the patient for 1 day or 5 days. So always actually a proper counseling is very important, because later parents should not tell doctor, you did not tell me all these things. That's why in the beginning I told documentation is very, very important. And years of practice actually will teach you, but we should learn from our from the history, not from our own mistakes. So that's why actually documentation is very, very important, and clear counseling is very important. And if at all, if we are doing laparoscopically, we'll be going away from the umbilicus, and then we'll be putting three ports, and then we'll be doing the surgery. Yes, three ports, 3 mm. Yes, scars are still definitely better compared to umbilical, because we want to leave the umbilicus like that only. We don't want to disturb it. So two schools are okay, acceptable. Both are equally good, but our solution is settle the problem. And another most important fancy item which all of us are very much interested is intussusception. So why intussusception occurs? Can we prevent intussusception? What is the solution for intussusception? Is operation the only answer, or can we do something else? So we'll discuss in the coming slides. So intussusception is something which we see so commonly, and that is mainly it starts with the weaning period. So मेरा boss used to tell actually बच्चा रोता है सोता है. So child will be crying, and after some time actually he'll be tired and he'll relax, and then he'll start crying again. It is because of the continuous peristalsis of the intestines above this intussusception mass. So intussusception actually it can be because of the lead point. It can be without a lead point as well. So the common lead points actually in weaning period is because of the hypertrophic Peyer's patches, which all of us see. So hypertrophic Peyer's patches actually it will lead to actually be thought by the proximal intestine as some intestinal fecal matter or something. It'll try to push it, and then it will lead to intussusception. And intussusception can keep on progressing actually if not tackled or dealt with properly. So uh, I'll tell why I use the word dealt with properly. So if intussusception progresses, sometimes it will go almost into the rectum. So that's why actually all of us will be seeing about a differential diagnosis of rectal prolapse and intussusception mass coming out of the rectum. So if finger is going all around into the rectum, it can be intussusception. So it is very rare nowadays because of advanced clinical acumen and advanced radiological tests, ultrasound, and then immediate availability of the pediatric surgeon. So I said dealt with properly, because if it the easiest way of handling the intussusception is by doing a hydrostatic reduction. So hydrostatic reduction is you can use either air, which is called pneumatic reduction, or you can be using a barium reduction, or the hydrostatic reduction where we'll be using a normal saline. So if normal saline perforates into the intestine, it will be a saline which is going into the free peritoneum. So it is not going to cause much of a problem. So in hydrostatic reduction, what we tend to do is actually we follow the rule of three. So rule of three is actually we keep that at a height of actually 3 feet above the uh, patient level. So which comes to around almost 100 centimeters of water. And usually, actually, it is all time tested. Beyond 100 centimeters, there is a possibility of intestinal tear or seromuscular tears. So each episode, we'll give it for 3 minutes. After 3 minutes, we'll wait for some time. We'll give one more attempt. So that attempt we want to abandon. So after 3 attempts, if at all, if this is not working out, actually, ideally, we are supposed to stop this hydrostatic reduction, and then we have to proceed with the surgery. So that's why keeping the anesthetist, operation theater, and everything ready is the primary responsibility of a surgeon who is doing a hydrostatic reduction. So without all these things, actually, we cannot think of doing a hydrostatic reduction, because if too much of pressure or something is applied, there is a possibility that actually the intestine fluid has gone out of the intestine and it has perforated the intestine. So perforated peritonitis cannot wait. So we have to go in and do laparotomy or laparoscopy immediately as far as if at all if hydrostatic reduction is not working out. So coming back to the slide, actually when I was a postgraduate, actually we used to do so many laparotomies. So in the second and third years, actually we started doing hydrostatic reductions. We have significantly reduced our actually laparotomy rates significantly by around 80%. So hydrostatic reduction is a real wonder treatment, because we are giving a treatment without making any cuts on the abdomen. So a successful hydrostatic reduction, when we call it, this is what we call it as a donut sign, actually, where we are seeing a one loop in the other loop, and little bit of rim of fluid or fecal matter or the air in between. So while after giving actually adequate fluid, actually this is how we see the normal saline going into the colon, and you can see the ileocecal junction, and it will open up, and then the small bowel actually will get filled. That means actually suddenly actually baby will start sleeping comfortably. Rota hai, bacha hai, suddenly he starts sleeping comfortably. That means actually it is a successful hydrostatic reduction. So if it fails, yes, actually we should be ready to go for a laparotomy. There is one other interesting topic actually, that is transient intussusception, which we see seasonally in some seasons, especially rainy seasons and all, post-rainy, and where there is mild infection, mesenteric adenopathy, mesenteric adenitis will be there, and or gastroenteritis can be there, which can lead to what we call it as a transient intussusception. Usually, I tell actually discuss most of with my pediatricians. I tell if it is less than 3.5 centimeters width, that means it might be a transient intussusception. It has not gone into the colon. If it goes into the colon, that is when actually we have to think about doing an operation. Otherwise, actually, we can manage conservatively. So, transient intussusception is a medical problem. It will be with the pediatricians. Real intussusception is the one which is going to come to us when it needs some procedure, hydrostatic reduction or laparoscopy or laparotomy. So this is the typical ultrasound report actually, which we will be seeing a lymphadenitis and pain in abdomen, and then so radiologist will tell, I saw that and I am not able to see it. Or today in the ultrasound he'll tell it is there. Tomorrow in the ultrasound it is not there. So that is when we'll be thinking actually it is a case of transient intussusception. The answer is simple bowel rest, and of course actually for gastroenteritis we have to give a bowel antibiotic, and with these two things, usually this will settle. So I said actually I discussed, can we prevent? Yes, interception is completely in the hands of especially the one actually primary one, actually idiopathic one, where we call it. It is only because of the prominent Peyer's patches. It is preventable. So because if you can give actually timely feeds, means 1 week actually continuously we'll be giving actually one new item, so that we will just check whether he is able to tolerate. Then we'll add on one other new item, and slowly we'll start adding all of these things. And third day, third week, fourth week, every week try to add one green leaves, one vegetable, one fruit, and along with that. So we should tell clearly the parents not to be in a hurry to go put the baby to obesity. So often we find a X-ray like this. So in this, the first doubt we'll have is whether I should go in or not, and surgeon will decide. And then whether I have to do a laparotomy or laparoscopy. So if you see, actually some loops are there. Actually, right elyphosa is looking simple, and this dilated loops are seen more towards other side, on the diagonally opposite side. So here, seeing this X-ray, we should be thinking that is it a case of actually appendicitis leading to ileus or something, so or some additions. So in this case, actually, earlier when laparoscopy was not available, so what we used to do is actually we used to do a laparotomy. So nowadays, with the advent of laparoscopy, our open appendectomy rates have significantly reduced to around 98%, by 98%. So appendicitis is a clinical diagnosis. Actually, so many interesting, fancy signs are there. But most important signs are actually, one is a rousing sign, actually, where we'll be pressing in the opposite lower quadrant, and you will be finding a pain in the right elyphosa. And psoas, where it is actually retrocecal appendicitis, actually psoas pain will be more, actually, if at all, if you hyperextend the hip joint. And obturator pain, where you try to medially rotate, then also you will find actually there will be appendicitis. So most important point is appendicitis is a clinical diagnosis. Around 100% of the time, actually, if the surgeon thinks that actually it is appendicitis, it is appendicitis. So, but unfortunately, in this era, actually, parents ask for ultrasounds and CT scans. So, ultrasound, unfortunately, the sensitivity is only 70%, which is my thesis as well. And CT scan gives almost a sensitivity of around 95%. Again, if you can understand, here also we are finding a non-pickup rate of around 5% in CT scan or 70% ultrasound, 30% ultrasound. So again, coming back to the clinical diagnosis, clinicians' evidences, that is very important. And appendicitis is uh, a clinical diagnosis per se. So with minimal bare scars, actually nowadays, actually all the pediatric surgeons are able to give the wonderful treatment by not operating. Even in complicated appendicitis also, actually laparoscopy is the answer. Recurrent abdominal pain is one of the interesting thing, and appendicitis can be recurrent actually, cause for recurrent abdominal pain. That's mainly because yes, actually the clinician actually missed it, radiologist missed it, or the family was not reluctant. They want medical management only, and sometimes we'll be forced to give medicines actually because family tells some stories. We are going out actually, we'll get it operated there, so we'll fall in their trap. We should never fall in their trap. Mesenteric adenopathy is a common condition actually where actually it will lead to recurrent abdominal pain. The answer is simple: medical management. And bands, actually, as we discussed, are common causes for the subacute obstructions and recurrent abdominal pains. And the intestinal duplication, cysts, masses, all these things, they'll be going into some volvulus or torsions. Because of this, actually, it can lead to recurrent abdominal pain. The and some luminal polyps can be, lead to intussusceptions, and it can be a recurrent abdominal pain. And ovarian cysts, masses, and torsion are a common cause. And malrotation of the gut is one thing which all of us should keep it in the mind and then actually evaluate and then operate accordingly. Constipation is one bottom line, and we should never ignore. That's the most important cause, around 30%. So laparoscopy is answer for recurrent abdominal pain, especially when if it is turning into a chronic appendicitis, and especially in girls, I tell, because local adhesions can lead to ovary and fallopian tube issues, and it can lead to long-term infertility. So especially in girls, when it is when in doubt, so laparoscopy is the answer. So early operation, especially in girls, is very important, and laparoscopy is a simple answer, and it also diagnoses actually if at all if it is a ovarian pathology. And the midgut rotation, malrotation is one thing we all of us discussed. Actually, in this, the C loop is not well formed, and the intestines will start going. A small bowel will be going into the right iliacus, right lower quadrant in the beginning, and then it will start coming out. And orientation is totally different. So this clinches to the diagnosis, and malrotation is an emergency because it can go into valvulus any time of the day. So LATS band release is the first step, and then straightening of the duodenum is the second step, and orienting the small bowel on the right side and the large bowel on the left side so that really there won't be any problems at all in the future is most important. Now, if you can see, appendix is going into some abnormal weird position. So diagnosing and operating on a appendicitis in this patient will be very difficult. That's why invariably we'll add on appendectomy. So in a malrotation operated case, all of us should understand appendectomy must have been done. So we can't diagnose it as appendicitis in his lifetime at all. Gallstones is another condition actually which can lead to pain or pain, and so especially the stones which are sitting in the neck of the gallbladder, which can lead to jaundice, and it can be a common core source of pain, and it can lead to infection, and sometimes it can lead to perforation also. So calculus cholecystitis and acalculous cholecystitis are quite common. Laparoscopy is the answer nowadays. Hemolytic anemia should be ruled out actually before thinking about anything. And hydronephrosis, I told actually Dietl crisis, huge obstructions, very rarely they can lead to pain. But a Dietl crisis is one condition actually which can lead to pain. The answer is simple: get rid of this actually huge obstruction or do a pyeloplasty anterior to the vessel. This is the answer. And laparoscopic pyeloplasty, nowadays actually we are advancing into the robotic pyeloplasty, which we do at KIMS Cuddles regularly. These are the answers and immediate solutions. So hernia is something which all of us know actually is a common cause for actually pain abdomen, because it can go into intestinal obstruction, irreducibility or strangulation at any point of time. And whenever we diagnose actually inguinal hernia, the answer is parents will ask, can I wait for years together? Then the answer is get it as soon as possible because it can go into irreducibility, obstruction, strangulation. Again, here documentation is very important. If we can document, we are always safe. So even if child goes into any of these complications, the answer for the inguinal hernia is nowadays laparoscopy because we can see the opposite side also. So which is always a doubt actually for everyone. So this is one interesting slide actually I made for myself. So if at all, if the umbilicus is protruding like this, then it means it is a umbilical hernia. If the umbilicus is protruding like a smiley, actually it means that is a supraumbilical hernia. Supraumbilical hernias need surgery. No need to wait for 3 years or 5 years. What we tell is in regular umbilical hernias. So supraumbilical hernia needs surgery because all these hernias again they can go into irreducibility obstruction. So let us not wait for that. And fatty hernia of linea alba is something actually definitely it needs because it's very small opening. Colorectal cyst is a diagnostic clinic of interest. So colorectal cyst needs to be operated, and usually the presentation is uh, pain, jaundice, or a mass. So if this triad is there, then an acute stretch, suddenly hemorrhage into a colorectal cyst can lead to severe pain. And sometimes actually perforation of the colorectal cyst can happen, especially when they go beyond 15 centimeters or more. Then there is a possibility of perforation. Then also the answer is actually laparoscopy or robotic surgery nowadays. We are not doing any laparoscopy open operations. So the answer is actually simple. We do actually excise the cyst because there can be a possibility of malignancy, and then we do hepatico-duodenostomy. This is the simplest operation actually where we attach the duodenum actually directly to the hepatic duct. So with the advent of this minimal invasive surgery, these are the scars we are going to give. And if at all, if we don't follow this, actually, this is what we'll be leaving on the abdomen actually for lifetime for the child. So abdominal cysts, they can go into torsion, they can go into volvulus, they can go into acute stretch, hemorrhage. All these things can lead to pain. And the answer is simple. Actually, laparoscopy is one single standard answer. And sometimes actually even hydrated cyst also actually can lead to acute stretch, and especially when it is infected. And nowadays, actually, minimal invasive surgery is one more answer for this. So this is one of the condition we operated. Very tricky, very scary operation, yes, but it is doable. So this child actually came with recurrent lower respiratory tract infections. We diagnosed that this child has got a Morgagni central hernia, that is Morgagni hernia. If at all, if we do a laparotomy, it is going to be a major laparotomy, and that's why actually nowadays the answer is a laparoscopy, where we'll be going in and doing a minimal operation, and then we'll be achieving the same result. So this is one interesting presentation I want to do. So like, sometimes all of us will be in a similar situation, what to do, actually abdominal distension, is it gas, mass, or fluid, should I call the surgeon or not? So one day I got a call from a pediatrician telling that he has abdominal distension. All the history I could get is it's a post-enterocolitis, abdomen is distended, and it may lead to ventilation also. We are thinking of ventilation, not passing, no vomitings, not passing stools, no airfield levels. All that he's telling is come as soon as possible. With this, actually I asked, actually, is there a bilious aspect? He said, actually, we are not able to pass NG tube, and then we are not able to pass the flatus tube. Come soon, actually, it is stony hard abdomen. So all I had to do is rush in and as early as possible. This is what is the typical X-ray actually we may be seeing. So where actually it is loaded with something, actually gas, fecal matter, or constipation or anything, but all the outlets are shut. This gastroesophageal junction is shut, and the rectum is shut, anus is shut, everything is shut. So this is a case of actually post GE actually where actually most important thing actually we anticipationally retrospectively what we should think is a bladder pressure needs to be monitored, and the answer options now left with, should I go in and do a laparotomy, should I do a drain, or should I just wait? So you can see a differential actually saturations as well, actually, which says that actually the child is in trouble. So then I went in, actually, I saw this one that actually anus is pouting, the posterior anal wall is pouting. You can see that upper abdomen is or paler, actually lower abdomen is congested. So actually even the veins also, if you can see, actually it is seen only on the upper side and it is going away from the umbilicus. With all these things, actually we came to the conclusion that it is a case of abdominal compartment syndrome. So operation is not the right answer. The early prevention, early suspicion, early interventions are right answers. If at all, if it is ascites, do a ascitic tap. If at all, if you can see, actually the feeding tube has come and gone up like this, and the feeding tube in the urethra is not going in. So in this situation, yes, we have gone to a point of no return. Actually, nothing can be done. There are several causes for intra-abdominal hypertension, and the most common things that we see in our practice, NEC, it can be a perforation, gastric extension, and even when doing hydrostatic reduction, I have seen once in laparoscopy, if the pressures are not monitored, it can go into abdominal compartment syndrome as well. So first it will go into abdominal pressure increased, and it will go into abdominal hypertension, and then it will lead to a full-blown abdominal compartment syndrome. So we should not let it progress. So normal abdominal pressure is 5 mm. In pediatric age group, there are no nomograms, but we have to make our own nomograms. And most important is actually the perfusion is reduced for all the organs. That's what we can understand. So the treatment is avoid overly aggressive fluid resuscitation. Early suspicion and early diagnosis is most important, and timely decompression is very important. And slow decompression should be done. So we should not be in a hurry to do a laparotomy. The moment you do laparotomy, the baby will die immediately. This is what we saw in one of our cases. In front of me, the bowel, which was good luster bowel, has become like this actually. So, is it too late? Yes, it is always too late. So, better do it. Actually, better prevent it. So, just few words about abdominal trauma. So, blunt injury and penetrating injuries actually are the common causes. So, children are more prone and more susceptible because they have very poor abdominal fat pad. So they are very prone to go for blunt injury abdomen. A fast is something actually all of the pediatricians are doing nowadays and in the year. And with this, actually, we'll be able to compare of conclusion what it is. And if the X-ray is showing actually gas under diaphragm, yes, actually it needs a laparotomy. If multiple atrial levels are there, yes, it needs a laparotomy. So, so many flowcharts are there, and it is individualized according to the institutional protocol. So, I'll try to skip this slide. So, nowadays, actually, we are going more for the preservation rather than removal of the organ. Be it spleen, be it liver, we are trying not to remove it and we are trying to conserve, and salvage is the most important management. So abdominal trauma is something which we all of us should understand and we should not ignore. And hemoperitoneum, sometimes actually hemoglobin can drop significantly, and simple cycle handlebar injuries actually. So for that, actually, whether we have to do laparotomy or whether we have to involve the interventional radiologist and do the closure of that bleeding point is most important. It needs to be assessed individually on according to the patient base. So one thing I want to tell is actually omental trauma, where a simple hematoma or necrosis of the omentum actually it can lead to severe pain, which mimics appendicitis. And there are many conditions, many kids actually who underwent laparotomy or laparoscopy for this omental trauma. The answer is a typical history of football injury or some injury or rugby injury, and then actually they'll be going into omental trauma. And the answer is simple masterly inactivity and taking care of the pain is the answer. This is one condition where actually where we had a traumatic injury and just blunt injury abdomen. What we found out is actually there's a hole in the diaphragm and the diaphragmatic hernia, and then actually we repaired, and that is the answer. So collateral observation is also very important. That's why reading Sherlock Holmes is very, very, very important. So always we have to think twice before making any decision. And because some baby's life is under your and some family and some so many emotions are there. So I always tell two minds are always better. So that's why actually that nowadays it is become a practice. to involve as many consultants as possible who are involved in this management, because that way the margin errors will come significantly down. So again, coming back to the point, abdomen is a Pandora box, even after all these actually evaluations and all. So take home message, don't miss the compartment 10. And that is very important. Kids, especially adolescent boys, will never tell us what is bothering them unless you go in and pester them and go in and remove his pants and then see. And pediatric surgeon in this situation actually of actually severe tight abdominal pain where we have to scratch heads is definitely a savior and use him. And constipation is most neglected cause for actually pain abdomen or distension. As my boss said, reevaluate and reassess after giving enema is a wonderful take-home message actually that all of us should understand. And with this, actually, I tried to conclude in 1 hour. Actually, of course, it is a very massive topic. If at all, if anyone is interested in asking any doubts anytime, actually, we will be as a team and we'll be ready. And Dr. Nitin will be continuously in touch with you. And I'm so happy that actually ours, mine is the last one, an interesting topic. And yes, big topic. But I tried to cover as much as possible. And thank you all. And if at all, if any questions are there, I'll be very glad to take them.
So there are two questions at this moment. Dr. Shravan Gupta wants to ask if there is any contraindication for anemia.
So, means clear, even when I am in the student life, I was told appendicitis, enema should not be given. It can lead to perforation. Yes, I think the only contraindication for giving a not giving enema is if at all if you are suspecting a perforation or an impending perforation in the colon, which is very rare. And usually, if at all if perforation is there, gas in the diaphragm, yes, we won't give any enemas. So enema is a wonder drug, just believe me.
The second is, should a trial of medical management to be given to acute appendicitis if symptoms are not severe?
So I means frankly speaking, recurrent appendicitis or a chronic appendicitis comes only after the episode of acute appendicitis. So if at all, if we have a diagnosis that it is acute appendicitis, the answer is laparoscopic appendectomy nowadays. So that is because if you don't do appendicitis, actually it is going means and parents sometimes actually they insist that actually please try to give medicines because it will go into recurrent appendicitis. And especially when fecal is seen in the or appendical is seen in the appendix, definitely it's an indication for removal of the appendix. But I personally tell as a surgeon, not because actually I'm going to get a case, appendicitis needs appendectomy because it is going to be a recurrent problem. So we have to go in and do appendectomy. There's no role for medical management. And earlier, actually, when we were studying the Orsner-Scherer regimen, these are all funny terms. But actually, nowadays, even perforated appendix, actually, we are going in for doing a laparoscopic appendectomy. And the laparoscopy is definitely indicated for complicated and complex cases because the access that we have and the equipment that we have are tremendous. Or else, for the same operation, we have to do a very big cut. And even for perforated cases, actually, we do and settle the problem. There is no relook operation.
Sir, Dr. Praveen Selvaraj wants to ask how much saline to be used for hydrostatic reduction.
Uh, so, uh, actually, it all depends on the age of the child and the colon size. So, we have done a study, but in that study, what we understood is usually each episode will require at least one 500 ml bottle. So, so there is no limit for this much of volume. So after what happens actually after the colon is filled, it will stop going. So from our study, what we understood is actually one bottle is required. So invariably, whenever I'm going for a hydrostatic reduction, I'll ask for the 2 bottles because if at all if I want, I'll add one more. Or if at all if I'm doing it the second, I told you no, actually we have to do it in three, first one, second one, and third one. So in these three times. So I may require 2 or 3 bottles. So 2 or 3 bottles should be arranged when we are doing a hydrostatic reduction.
So Dr. Mrudula Palla asked about what is the treatment for constipation in early infancy. I
So,
think
and the
pediatricians.
but actually, I mentioned in the interception prevention slide. So weaning is very, very, very important. Actually, means parents will be overzealous. They want to be see that their baby becomes actually a chubby baby or a huggies diaper baby or something like that. But we should tell them clearly that you have to introduce home food and not processed food. And most important, green leaves, vegetables, fruits. I always tell the parents actually don't use grinder. So what our grandparents used to do, try to follow the same one. Boil it, mash it, and then give it. So we have to give slowly one after the other, and this is how actually you can prevent a constipation. I always actually in my computer in my OP chamber, I have a full folder which has got fiber diet. So I show them in detail, and I take a really long time. So that's why I always tell whenever a constipation child comes to our OP, he's going to eat around 30 minutes of your time, and he is never happy. That family is never happy because of the constipation. So detailed history and detailed treatment is very important in the case of constipation.
Sir, Dr. Jalil asked about wait and watch for Meckel pathology. What is sir's opinion?
So Meckel's actually, I discussed actually, Meckel's diagnosis itself is very difficult. So Meckel's diagnosis is done if at all, if Meckel's scan is showing Meckel's diverticulitis, then only you'll see the metal scan positive. So if at all, if metal scan is positive, that is going to lead to recurrent abdominal pain. So definitely, we have to go in and we have to do a laparoscopy, do a resection of the metal scan, metal's pathology. So, but I told in our presentation that there is an incidental metals scan which can be metals diverticulum which can be seen. Incidental metals diverticulum, if at all, if the base of the metals diverticulum is very wide, there is no need for operation. We can just leave it like that also. Lifelong, actually, he'll have metals diverticulum. It's an incidental finding. But clinically, if we have found out that it is metals diverticulitis or metals leading to bleeding, uh, so that is definitely an indication because it is never, it's an ongoing process. It is never going to stop. So he needs to be operated.
Sir, Dr. Shirinder asked few lines about medication to relieve pain abdomen. And Ganesh Rao, Mr. Dr. Ganesh Rao is wanting your opinion on mesenteric adenitis. Is it only medical management or surgery?
Mesenteric adenitis is pure medical condition. Actually, it needs to be managed uh, medically only. So very rarely we may be thinking actually it can lead to abscess formation, but it is usually seen in post-tuberculous or sometimes what we call it as a pseudo-mesenteric cyst. So where in the base of the mesenteric adenitis, actually if it goes too much, it can lead to pus formation, but it is very rare. But in this era of actually usage of antibiotics and early management, so this possibility is very unlikely. So mesenteric adenitis is always a medical management. It needs to be managed by pediatricians only. So few lines about medical medication or to relieve the pain abdomen. Pain abdomen is a common condition that actually all of us face, and immediately all of us are giving actually the most important. It again goes back to the what is the cause. So if the cause is because of the intestinal dilatation, is the one which is going to cause intestinal pain. So we have, and it is because of the spasms of the intestines. So reduce the spasms by giving appropriate dosage of antispasmodics. To such an extent, I add on actually. I sometimes I take 1 cc of actually some antispasmodic. I dilute it to 10 cc of NS of water, and then I tell the sister to give it actually every time mother complains to give one shot. Sometimes placebo effect also works. So whenever if the patient is admitted, the placebo effect should not be ignored and it can still be given. Yeah, then that'll in constipation actually, and enemas are one of the wonder drugs.
And Dr. Nikhil Dholpur asked sir, in SAIO, what is how much time should the patient should be managed conservatively by keeping NPO and Riles tube?
So usually we wait for 2 or 3 days. After 2 or 3 days, usually we don't wait, and we'll proceed with the management. surgical
Sir,
management.
in continuation to your pain abdomen, Dr. Shailendra Kumar Das added that when should we use Contramol or Buscopan or Rotavirus?
So, frankly speaking, actually, all of us know that all these medicines actually are going to work in the same fashion. So the answer for this is one after the other. So it all depends on actually parental happiness is also very important, and most of these actions are same. So stick to one thing and then continue that. And if the parents are unhappy, then only we can add on something. But usually the modes of action are same.
I would like to add to this question, sir, that
Yes, thank you.
try to find out the cause for pain rather than giving a symptomatic treatment with Buscopan, Rotavirine, or even painkiller. Because if you do not resolve the cause, after 4 hours, your night will become into nightmare. There will be a lot of trouble which will come across. And usually, the cause of pain in constipation is mainly the motion itself. And if it is an organ in intussusception, it is colic because of the lead point. And if it is appendicitis, then it is inflammation of an organ. Until and unless we resolve it, we are not going to take care of it. I think Yoga sir need to leave and has left. I'll take all other questions in the group, and it was an amazing presentation, Yoga sir. For Dr. Wilsat, I will definitely get back to you for those questions who have remain unanswered. Please ping them to me on this number which I'm sharing on the chat box, and I'll make sure that you get your replies. It was an incredible journey on Pacman and amazing support by Pawan sir, Shri Krishna sir, and Team IAP with PATS has made our life easier and our academic growth happier. And with all of you joining it with your busy schedule, it makes even a great experience for all of us. Thank you. I'm Dr. Nitin Chawla, and it's a great session that we all have seen together, and it's a great journey which we all are on it together. Thanks a lot, everyone. Take care. We will end this talk now.